16-year-old female, gymnast, presents with fatigue, amenorrhea, and weight loss. Her BMI is 16.3. Now, if you're a clinician, you are probably trained to spot that patient as a classic eating disorder case. But what about the 9-year-old who's labeled a picky eater, who's not only falling off their weight curve, but their height percentile as well? Or the 40-year-old who's obsessed with eating clean, but also shows signs of malnutrition? Or maybe the teen who says they're fine, but you just know something's off. I'm Colleen, a PA, dietitian, and your nutrition mentor. Welcome to the Exam Room Nutrition Podcast, your guide to giving better nutrition advice. Today, I'm joined by Johnna, an eating disorder dietitian who's here to expand the way we think and talk about eating disorders. She'll walk us through the subtle clues providers may miss, how early feeding habits influence adult behaviors, and why so many patients with disordered eating don't fit the mold we were taught in school. You'll also learn why it's so important to refer to a dietitian who specializes in eating disorders and how to actually find one. We'll talk about what treatment really looks like after you make that referral. Because I don't know about you, but once the patient's out of my office, I've often wondered, what happens next? You'll also get a crash course on ARFID, how it differs from picky eating, and why it's so often missed in practice. And we'll close out the conversation with a really thoughtful discussion about the phrase healthy eating. Is it a motivating phrase, or could it be doing more harm than good? Johnna also shares some helpful websites, conversation starters, and the exact questions she wishes more providers would ask. This episode is your crash course in how to screen smarter, refer sooner, and support patients more compassionately. So get comfy and enjoy my conversation with Johnna. Johnna, thank you so much for coming onto my podcast. Welcome to the show.
Of course, Colleen, excited to be here. Excited to share some great things about eating and feeding and how do we really better help our patients.
So I wanted to first unpack the psychology of eating because I think this is an important place to start. So if you could just explain to us, what are some of the biggest drivers of eating behaviors that go beyond just hunger?
I mean, so many people think it's just that primary component of, oh, are you hungry? Are you not? But this goes all the way back to satiety of connection, right? So much of what we do for feeding and nourishment is how are we connecting to our community, ourselves, our body. And I even think back into the womb is where it begins. That's our initial component of connection. All through elementary school, childhood, think about kids' birthday parties, your favorite dinner that you do with your family. When we don't have that connection either internally or with the community, that's where you start to see this disconnect of you don't really even understand how hunger is fueling you. You don't quite understand how are you connecting with your body's innate hunger cues.
Yeah. Oh, I love that you went there because I'm all about connection, whether it's with our patient or with ourselves. Can you walk us through exactly how the disordered eating patterns actually start? And then maybe what are some early signs that providers should be aware of?
So many people, I think, just go to their physician and think it's just a regular checkup. Oh, my brittle hair, my nails are a little drier. I have these chronically chapped lips. I have some extended abdominal bloating, but that's just all normal, right? That's just what I'm eating. And when you look a little deeper, it's like, well, these are actually some early signs that your body is struggling for adequate nourishment. Your body is struggling to appropriately have that mucosal membrane, to have enough energy to promote adequate digestion. And while it may seem quite simple, if you might just skim by it, when you're noticing those components on like a physical exam, maybe it's the dullness of the skin. Maybe it's some like bruising in the throat, some petechiae. Maybe it's something just a little off. I always encourage providers, don't just let that slide as just something that's been here for a little bit. Ask that additional question or two. When you think about other early signs, pediatrics is such an important part of what sets us up for success in life. And the whole picky eating thing I hear so frequently. Oh, my kid's just a picky eater. Oh, my kid has just chronically always been a small kid. That's just who we are as a family. But that often phases out by age 5. That's the thing. And after age 5, you really should start seeing those picky eating habits fall off have a more stable set of eating, really start to see more appropriate trajectory on those growth charts, not only for weight, but also for height. And if you're not taking appropriate intervention between 5 and puberty, you could really be setting this patient up for a lot more struggle than they intended by not having those earlier conversations. Because I see that a lot where people look back and say, I wish I would have known. I wish I would have known. And if we have those conversations earlier on of, yeah, let's look at that 5 to 15 age range when you're really setting up these eating and feeding behaviors, those are those early warning signs you want to look at.
When we were taught about eating disorders in school, we saw the picture of like an emaciated young teen. Typically the story is she's a gymnast or a ballerina or even maybe like a cross-country runner. And so those are like what we kind of imagine in our minds of patients who are like, oh, we got to be aware of these patients. So I would love to hear if there are other populations maybe that do get overlooked because they don't maybe look like those patients in our textbooks.
It's so overlooked and so simplified where, yes, that is a type of patient that has a severely low body weight, that is having cardiovascular issues, that is having cognitive issues, that really does require an inpatient stay to make sure that they can appropriately renourish themselves, making sure there's no refeeding syndrome happening, making sure that they can have possibly tube feeding to assist, but that can also all be presented in somebody that looks, quote unquote, like a normal patient. That's a narrative that I find is extremely antiquated, that you have to be one type of body to have an eating disorder. I'll never forget this one lady. She was mid-60s in a residential care facility. So essentially the patients will come there. They'll live there for 4, 6, 8, 10 weeks at a time to have supervised meals, medical staff on hand 24/7, but not to the high level of acuity you need inpatient, right? She was blind. Okay. So for anyone that's out there that says, oh, it's all about how I look, this is a woman in her 60s that could not see how she looked and still presented with disordered eating patterns based on her intake, as well as her high selectivity of foods that she was able to bring because she was so fearful of gaining weight. That's one of the biggest things you'll see too, is just those hallmark signs of what are the fears of eating? When do you feel out of control with food? When do you feel like you just can't even choose and there's nothing to eat, so I'd rather just not? Those are all pretty strong indicators that this is outside of body shape, weight, and size, and this is more of a psychological component. Hence why often I am partnering with a therapist on board or a psychiatrist to make sure that the mental health component of eating disorders is treated in conjunction with the nutritional rehabilitation.
Yeah, I really like how you stress the importance of having those deeper conversations. So I'm curious if you can give us some ideas of like, okay, what does that exactly look like? What are those questions that the provider can ask the patient to get more information from them? Maybe they do see some of those physical signs, maybe they don't, but what are some questions that providers could start asking?
So I always tell providers, don't be afraid to ask these questions. Often people kind of tiptoe around eating disorders and disordered eating. They don't want to make things worse. It's okay to talk about weight changes without having to emphasize you have to be a certain weight to be quote unquote healthy, right? Even integrating like an EDEQ, one of like the standardized gold components of how we're assessing for eating disorders as part of your onboarding paperwork. That way it can be a really quick AI driven, what's going on? Are they screening for high EDEQ? Should this be a further conversation? And then you can refer out appropriately. But asking questions too of how has your stool been? What is your urine output? And a lot of these patients are coming in saying, no, like I'm trying to just take care of my body. I'm trying to eat like I'm supposed to, quote unquote, clean. And asking maybe even to, okay, well, how long have you been eating like this? What promoted the change to try this new intake pattern? What do you even like about eating these foods? Because a lot of people that are in these disordered eating patterns, they have extremely safe foods that they will lean towards, whether that's because they know the caloric component of the food, they know that control factor of it, or they just know that every other food is so scary to try that it's not even worth trying. So having conversations of when did we first start eating like this? How long has this been? What else are we even eating? You'll see a lot of those restrictive mindsets for the restrictive type of eating disorders where it's extremely rigid and they're not willing to break out of anything different. And on the flip side, when you're seeing individuals that have an eating disorder where it's overconsumption, right? You want to understand, okay, well, how many times a week are we having these binge eating episodes? Sometimes the patient might not even be aware that it's a binge eating episode. They just think, oh, it was a really stressful day. I just blanked out and ate X amount of food and I wasn't quite sure what happened. But that's why it's so important to, whenever physicians or providers have a concern of something's just not quite right, it's probably not quite right. We're all like very savvy individuals where we've been in the field for quite some time. Even if you think there is some concern of this has to have a longer conversation, if you only have 15 minutes for an assessment, refer out to an outpatient dietitian. An outpatient dietitian is really just there to facilitate conversations, have a space for patients to know they can talk safely about food, maybe explore this for the first time, or maybe say, this is my 5th time I've gone through the ringer of eating disorder treatment and I don't know where to go from here. I think that's something a lot of providers need to be more keen to, is knowing the community of dietitians that are either local or even right now, like having this virtual healthcare has been an amazing asset to individuals that are in communities where there isn't a dietitian within an hour drive. Physicians should be able to have on deck some outpatient dietitians they can refer to.
Okay, there's a lot to unpack there. You just dropped so many helpful things.
I know.
But I want to linger with having an outpatient dietitian that you can work with, because I fully support that and agree with you 100%. But a lot of kickback, and from what I hear from my colleagues, which are PAs and NPs, is I don't know where to find these dietitians. So can you give us some resources, especially if we are concerned about possibly disordered eating? What are some of those first steps? And maybe how do we even find a dietitian who we could connect with?
Great question, because it's exactly how patients feel, right? They're like, I don't know where to go from here. I think there's a problem. Where do I even start? Healthprofessionals.com is like where we even find other health professionals. Dietitians are on there. I personally would only recommend someone seen that specializes in disordered eating and eating disorder behaviors. Now, that doesn't mean they need to have their SEDS qualification, but they need to have understood this population and not just say, oh yeah, I can kind of talk about food. It's a very specialized field of knowing how do you have those delicate conversations? How do you create a safe space for these patients to explore all the feeding and eating behaviors, either as a family unit even, or as an individual? Often a simple Google search of eating disorder dietitians in my area, there will be local chapters that have certain boards that are compacting each dietitian group. There are some larger organizations like Center for Discovery, Eating Recovery Center, and they can always, if you're not quite sure, reach out to them and say, hey, I'm trying to build up my outpatient dietitian list. You guys are a higher level of care for maybe higher acuity patient. Where else do I look? And they are always well connected, because after you leave a higher level treatment center, you don't just get left into the world, right? You get appropriately placed to a dietitian in an outpatient community. So they have a very strong team of admin group that can really connect a healthcare provider through a simple phone call too.
That was so helpful. So we're going to link to all of that in the show notes, but I would highly recommend you spend your lunch break or whatnot reaching out to dietitians. Find a handful of them that are either in your area or that are in your state that can work with some of your patients, because some of this is more detailed and nuanced, and it goes beyond our scope of practice. So I would highly recommend you team up with a dietitian. You will benefit your patients so much. Now, I want to get into like what treatment kind of looks like, because a lot of us, if we're not in this space, we sort of had no idea. You know, we would make the referral and then it's like, I don't know, we don't see these patients for like 6 months to a year. So what does that look like? And you can maybe give us a difference between inpatient and outpatient, because I know they're drastically different, but just give us an idea of what our patients are going to be going through.
I think that's such an important question, because the patients are completely unaware of what they're getting into, right? We need to be having these conversations with patients so they're not completely lost. So breaking down different levels of care. So we'll go with highest acuity to maybe a bit more like manageable without 24-hour medical supervision. Inpatient stay essentially is going to be at a hospital, right? Often you will be in a cohort with 10 or 12 other individuals, adolescent or adult, doesn't quite matter. Often you're there because you're having some cardiovascular abnormalities that require intensive supervision. Maybe you're having a tube feed with fluid replacement that just needs 24-hour care and maintenance. And often that's just there to stabilize a bit. Once you are medically cleared, you will then transition to a residential community. And that's going to be maybe 6 or 8 individuals where it's you have your own room, you have scheduled eating and meal times, you have therapy, and it's really more of a space for folks to say, I just need more support. I can't do this on my own. And that can look like a month stay. That might look like a few months stay. It just depends on how much support you need to make sure you can get through treatment. And not everyone goes to that level, right? It's very fluid of maybe you're going to be in a partial hospitalization setting where it sounds scary, but it's not quite the hospital. It's just like a full day, almost like a summer camp treatment where you're just having a few meals that you're supervised with, you're eating with others, you're having to just have a support system around you. And a new thing I've been seeing a lot of my colleagues do is harm reduction care, where if they can even find a physician that is willing to monitor and partner with them, maybe this patient's had a lot of scary and traumatic times through higher level of care treatment, and they don't want to go back. Like, this hasn't worked for me. If you have a dietitian that is trained enough in eating disorders to be able to manage this patient care with a physician that has agreed to work with a therapist as well, you could do a harm reduction model in an outpatient setting where essentially it's once a week visits. You're having maybe certain like food apps you're doing to track, okay, this was a day where I had some purging behaviors. This is what happened. This is a day that I had binging behaviors. This is what happened. And that sometimes can actually give a lot more power back to these patients where they know I can still take ownership of the challenges I'm having. But that's why I always say start in outpatient care. Like, let's start slow unless it is medically necessary to admit to inpatient.
I think that's awesome. I think that's less threatening and probably a little less, life altering for the patients to go through, like you said, that outpatient kind of treatment. So I'm also curious about a recovery. So I know in addiction treatment, there is a concept of like lifelong recovery. Does the same concept apply to eating disorders, or is someone, after treatment, are they just quote, healed all of a sudden they don't have to worry about this?
I wish I was a fairy godmother that could just say, okay, we're done. You're healed.
Yeah.
There's so many different types of what recovery looks like. And full recovery, quote unquote, I personally don't know if that is attainable, right? Because that is this hyper perfectionistic model of I have no disordered eating thoughts. I am operating perfectly. Everything is fine. I'm never going to go into remission, right? Where we have to remember this is as much of a mental health concern as it is a nutritionally impacted disease. So I think full recovery is really individualistic. Maybe full recovery for you looks like I can eat one full meal a day and the rest I have to rely on oral nutrition supplements, right? And that might be recovery for you, but it's not this one size fits all boop magic box. Working with your healthcare providers to say, what does recovery look like for you in a safe setting? That's where I think true recovery is possible. But for this general, all the boxes are checked, you're healed, you're recovered, that's not quite what I've seen as sustainable. But it does depend on how long this has been happening and the severity of the disordered eating pattern.
Yeah, it's very patient specific. Like you said, there's so many different factors that can affect that. So I actually interviewed a wonderful young lady who shared her journey of an eating disorder, kind of from like teenager life and what that looked like, and sort of her behaviors and things that the clinician said that were helpful versus harmful, and her journey through treatment. And actually, she's now in recovery. And so if you guys want to get an inside look at exactly what it looks like to be a patient who is working through an eating disorder, go listen to episode 41 after this episode. It's titled Silent Battles, The Secret Struggle of Eating Disorders. I think you're going to really love that episode. I would love to unpack your specialty, which is ARFID. So if you could kind of explain what that even means, because it's newer and I wouldn't be surprised if a lot of my listeners haven't even heard of it, and sort of how it differs from other eating disorders and your overall treatment of patients with ARFID.
Avoidant restrictive food intake disorder. Okay. It's one that you will sometimes see with any kiddos that are maybe on the spectrum that deal with some sensitivity issues. And there's 3 different subtypes of it, right? There is disinterest in food. Maybe they've just chronically never been interested in certain foods. that has then stunted their growth, similar that you would see in somebody that has a restrictive component of eating disorder. Then there is adverse reaction. Maybe they had a weird allergic reaction, their throat swelled up, and now they're so afraid to eat that they just aren't eating anymore. And that you'll see as a very quick drop, right? Where they've been very normal mostly with intake, and then something happened where they just cannot eat anymore and they're terrified, truly. And then the other is just high sensitivity to textures, to smells, to different elements, where if they maybe have 3 different foods that they eat for brand wise, and now manufacturer doesn't make the food, they're not eating. And the parents don't know what to do to feed their child. ARFID has been, I would even say, the past 5 years, one that people don't know what to do with these patients because they often don't have a fear of gaining weight. They don't have any general body dysmorphic concerns, and they don't follow the traditional model of how to treat a patient for an eating disorder. Because with ARFID care as a whole, though, it's a lot of staying creative, right? It's a lot of, okay, yes, you still probably need to go to either a treatment center or see an outpatient dietitian, because at the end of the day, it's impacting your ability to either grow appropriately if you're a kid, have adequate nutritional status, despite even not having any body image, weight, shaping concerns. But it's one that I really hope providers can be a bit more keen and savvy on of, oh, well, they're not concerned about their body weight, shape, or size. It's probably just some picky eating. We have to go back. Picky eating should not really be presenting itself in a normal setting from pediatrics through adolescents through adults. If it is still there, it is likely a sign of disordered eating that you'd probably want to refer out for an additional component. And one thing too, you'll see a lot with ARFID kiddos, it's not just the weight that's suppressed, it's the height that's suppressed. So when you're looking at these growth charts and you see that height is just a little tracking slow, that's a sign that something is a little deeper going on. And it's not just that they're small for weight or there's just a small kid. Ask a few other questions about intake, see where they're eating and see if there's anything else there that we're quite missing.
It's so fascinating. And you're right. They're often labeled just as picky eaters, and sometimes we'll dismiss it and say, oh, they're going to grow out of it, or just keep offering a variety of foods. And so those traditional tactics often don't work. So like you said, you got to be really creative. I would love to hear what some of those creative tactics actually look like for these kiddos.
My whole approach of how I'm doing feeding and eating is you cannot overwhelm these kids with so many changes. There are times where I've had patients that present with, they are not eating any solid food because they are so fearful of choking. And as a dietitian, I sit here and think, how am I going to make sure you have appropriate calories, protein, fat, everything you need to rehabilitate yourself? And a lot of it is exposure therapy, right? So you're exposing yourself to your 5 basic senses of what does it smell like? What does it look like? What does it taste like? What does it sound like? Even the crunchies can be really off-putting for some folks. And when you're able to take a step back and have it as more of an exploratory mindset, being focused on appropriate caloric intake is the number one thing over variety, hands down. Variety comes at the very end. So just because you're concerned, oh, my kid is not eating enough things, okay, let's make sure they're eating enough at first. Then we can focus on variety. So presenting your kiddo with a small little exposure every single day, say, just try it, smell it, lick it even. I know that sounds weird, but having just that small interaction, it's helping them stay more open to new foods. If, let's say, they only do one certain type of mac and cheese, okay, we're going to try a mac and cheese called food trading of, let's try a different brand. Let's try a white cheddar instead of a regular cheddar. Okay, now let's add maybe a little extra whole milk when we make it. Those are those small food tracking trains that really help these patients increase the variety after you've already established appropriate caloric intake.
Those are really, really helpful. So I want to talk about the phrase, quote, healthy eating, because we use it all the time and it means something different to everyone, basically. So I would love to just hear, how do you define what healthy eating is? And do you think this message is helpful or harmful in the eating disorder community?
I love this question. I would personally say, I don't look at the term as healthy eating. I think more helpful eating, right? What is going to be helpful for you to get through your day? Does that mean you maybe don't follow the traditional 3 meals a day of eating that was really set back in industrial times where you had set meals because of your work schedule, right? Maybe you think outside the box and your helpful eating pattern is 5 small meals a day where they are enough that you can have all of your nutrients, right? The healthy eating, guys, it's tricky. It can help people say, what is the best for my lifestyle? What's the best for me? What's best for feeding my kids? But changing that narrative of what is helpful for me today? What is helpful? How can I celebrate food outside of just making this when I have to do? If I want to go have a beautiful like slice of cake and I want to have a smoothie and then I want to have like a snack at the farmer's market from this amazing like crab croquette, food is supposed to be fun too. Like helping your life where it's not just about, oh, I eat all the things because that's what I need to do. I don't understand how it could be healthy for enjoying your life, because life satisfaction and community, like we've talked about before, those are all components of how are you helping to better your life. So I challenge my patients all the time and even other colleagues of let's skip that narrative of healthy and think what is helpful for us to feel best for ourselves.
Oh, that is so good. And it's so applicable to all of us, right? I mean, if you think of athletes, what's healthy for them, honestly, before soccer game, a Rice Krispies treat is probably healthy, but I love how you reframe that. It's more helpful for them because it's giving them that instant boost of simple carbohydrates, right? So I think that approach can work so well. You're going to get pushback, or I am going to, when I post about this on social media, because I've done this before and people will say, well, that approach doesn't work for people who have food obsession, right? Who like cannot control themselves and overeat and aren't mindful and anything like that. So just curious, like, what do you say when people push back to like that they do need more boundaries around food and just telling someone, well, eat what's helpful for your body? What would you say to someone who disagrees with you?
So I professionally don't agree with the whole food addiction modality being the same as binge eating, right? They're different things, but it's no different. Like if you're struggling with binge episodes or overconsumption of food, okay, what is helpful for you? Maybe that looks like we're having more compact meals that are more satiety inducing. Maybe that looks like we're having more structured eating times. Maybe that just looks like a bit more support, because when we're not having the support and structure, we're going to feel out of control and we're going to turn to food to feel some sort of just reprieve from our lives, right? The pendulum swings both ways of overeating, undereating. And you'll see that a lot for folks that are struggling with binge episodes. They'll then restrict right after because they have that shame-based modality. So the language should really be the same of what is helpful for you is finding an eating pattern that works. And just because you struggle with episodes of eating a lot of food in a small time doesn't mean that you shouldn't be eating food. Again, that is a one-time thing and your body still needs appropriate nourishment all throughout the day, every day. And that will be most helpful for you.
Yeah, no, I agree with you. And I think people often will push back on dietitians or argue with dietitians who, you know, take a food first approach and say that all foods can fit. And they sort of attack dietitians and say that we're just like promoting ultra processed foods and sugar sweetened beverages. And we're just letting our patients eat whatever, whenever they want. And I think they're misconstruing what we're saying and our approach. And that's why I love that you had mentioned what's helpful. Maybe for someone helpful is structured meals. It might be oral nutrition shakes. It might be more support from a dietitian or from a mental health therapist or something like that. So I think it's just our philosophy, or the majority of dietitians' philosophy, is misconstrued a little bit as just like willy-nilly, like you can do whatever you want. So I love that approach. And I think more clinicians need to start asking their patients, like, what would be helpful for you? Love that.
That's how you can really remove the shame-based language around food, rather than having such a pigeonholed approach of, oh, you have to eat this, you have to eat that. That's going back to like the healthy mindset, where that's where a lot of this unravels and stems from too.
Yeah. Which leads it to nicely my last question, which is, how do we balance the need to discuss nutrition and maybe their weight without triggering any of those restrictive tendencies in our patients?
It's a fine line to walk, right? You can still have all the conversations around helpful eating habits without ever talking about weight specifically. So as a provider, don't feel the need that you have to talk about weight in that setting. You don't need to. you can really focus on more of like feeding and eating behaviors, because the treatment modality will be the same regardless if we talk about weight or not. If you do feel nervous talking about that, you don't want to re-trigger someone, you think that they'll just close up, that's where you refer to have a trained provider that knows how to have those more appropriate conversations.
Very well said. Great place to end. I can just tell you're so passionate and compassionate in your treatment and your care of patients. So thank you for sharing that with us today. Now, if people want to connect with you, learn more about you, or just work with you, where can people find you online?
So you can go ahead and find me at fabconsulting.com. So Fab Nutrition Consulting Practice. And it'll be a great space if you have any other questions about how do we continue having these more productive conversations so you can better your patient care.
Great. And I will link to all of that down below in the show notes. But Johnna, thank you so much for the gift of your time. I love to have you back on, but for now, have a great day.
Thanks, Colleen. Take care.
If today's conversation got you thinking differently about how you screen, refer, or even talk about food with your patients, you're in good company. Now, it's one thing to learn the clinical side of disordered eating, but it's a whole other thing to hear what it feels like from the patient's perspective. So if you haven't already, after this episode ends, go listen to episode 41, titled Silent Battles, The Secret Struggle of Eating Disorders. It's a really powerful, behind-the-scenes look at a young woman's journey through secrecy, struggle, and recovery. And it just might change how you approach these conversations with your own patients. And while you're in the podcast app, would you do me a quick favor? Can you leave me a short review? Your words of encouragement help keep this show going, and it helps more clinicians find it too. So thanks for carving out some time for nutrition today. And as always, let's continue to make our patients healthier, one exam room at a time. I'll see you next time.